Hello, I'm Néstor López Cabanillas from Buenos Aires, Argentina. We'll talk about how to cross subclavian occlusions and perform venoplasty for venous access. You know that for a successful implant, we need the venogram to understand the venous anatomy, tools, and techniques to get access to the difficult anatomy to finally do a correct lead delivery. About the subclavian venogram, it's very important to do it. We usually do at the medial axillary vein using full contrast, 10 milliliters full contrast. When peripheral venogram appeared to demonstrate total occlusion, only 20% had total occlusion, and it's very important to use a hydrophilic wire. What are the tools to cross a subclavian occlusion and perform venoplasty? The contrast injection system and recanalization system is very important. It's necessary to have wires, an 014 wire, an 035 amplitude wire, and hydrophilic 035 wires. Also, it's very important to have these hydrophilic catheters with braid in the wall to provide torque control and pushability. The snare catheters are another tool, and the venoplasty balloon and inflation device. In some cases, it's necessary to do laser extraction. What are the techniques for a successful implant? Venoplasty, the use of hydrophilic catheters to interchange or upsize wires, extract the lead, leaving a wire in the vein using the wire and the insulation technique, wire in LV lead before extracting it, the use of snare, and the laser extraction. For total occlusions, there are some solutions like subclavian recanalization, laser to cross total occlusion with no leads to follow, and the patent vein of Marshall for coronary sinus access. What are the basics about balloons? We use for subclavian vein venoplasty, we use non-compliant balloons. They are very important, and if you compare with the other kind of balloons that are the compliant balloons that are used mostly for CS venography, the non-compliants have a retained molded inflation geometry and are thicker than the compliant balloons, and they increase less diameter with the pressure. What are the basics about nominal and rated burst pressure? The nominal pressure is the pressure needed to achieve the rated diameter. For example, if you have a balloon of 3.5 millimeters diameter, to reach this diameter, you need to inflate it up to 6 atmospheres. With overinflation beyond the nominal, the diameter increases slightly. And then when you finally reach the rated burst pressure, this is the maximum safe pressure beyond which the balloon may rupture. And then in this case, if you are using a 3.5 balloon, if you inflate up to the rated burst pressure, the diameter will increase up to 3.8 millimeters. There are different types of balloons, over-the-wire balloons and rapid exchange balloons. We usually use for subclavian vein venoplasty the over-the-wire balloons that are different to the rapid exchange balloons. You can see how the wire goes all the way from one side to the other in the over-the-wire balloon. If you compare with the rapid exchange, the wire comes into the catheter at some place of it. Usually the rapid exchange is an 014 lumen catheter, and in the other hand, the over the wire usually uses an 035 wire. And remember that this type of balloon is the balloon that we prefer. And why is it necessary to learn subclavian venoplasty for device implantation? Well, 10 to 30% of implants with prior leads have subclavian vein stenosis or occlusion. We implant more frequently in patients with prior leads. Implants require unrestricted catheter and lead manipulation. You can see where the stenosis are located in this slide. And what about progressively larger dilators? Well, venoplasty is faster, and using dilators, leads and catheter remain difficult to manipulate throughout the procedure. About central stenosis, they are not open if you use progressively larger dilators and gives a false sense of safety. Here you can see an stenosis far in the vein at the superior vena cava, and this kind of stenosis are not reachable using dilators. It's necessary to use balloons. For subclavian venoplasty, we use, as I told you, non-compliant balloons, over-the-wire balloons with an 035 wire. The most commonly used balloon is the 6 millimeter diameter and 4 centimeters length for adding one lead. If you need to add 2 leads, a balloon of 9 millimeters diameter is the best. Always dilate from the superior vena cava right atrium junction to the pocket in 4 or 5 overlapping inflations. And always inflate to the rated burst pressure. That saves time without increasing risk. And inflate until the pressure is stable and the waste disappears. Always perform the first inflation central because the profile of the balloon increases after the first inflation, and that's calling winging. For the difficult cases, sometimes it's necessary to add a second wire, and then you have to inflate the balloon against another wire. This is called focus force venoplasty. In some cases, it's necessary to use an ultra non-compliant Kevlar balloon. Another very important technique is the technique to upsize, and then how to interchange from 014 to a 035 wire. The tool is the hydrophilic catheter, and then if you have this wire in this vein, then you can advance over the wire the hydrophilic catheter, remove the wire, and advance a 035 wire. In this case, the regular wire, doesn't give enough support to advance the balloon. You can advance a hydrophilic catheter, remove the regular wire, and advance the Amplatz 035, and then do the venoplasty. See this case. We are advancing a balloon. You can see here, and look what is happening. The balloon explodes, and that situation was because the balloon was inflated beside the rated burst pressure. Sometimes it's necessary to extract the lead, leaving a wire in the vein. There are several techniques: the wire and the insulation technique, the wire in LV lead before extracting it, the snare technique from femoral vein, and sometimes you can use laser extraction. In this case, the lead is free in the vein. And then we proceed to advance a wire under the insulation, and then advance both the wire and the lead, disengage the wire, and then withdraw the lead. Then it's simple. It just upsize the wire and do venoplasty. In this interesting case, there is a LV lead dislodgement, and then we decided to advance a wire beyond the tip of the LV lead, and then we are removing the lead. We advance a hydrophilic catheter over the wire, and then upsize from 014 to 035, and finally do venoplasty to end the case. In this case, there is an abandoned RV lead, and then we proceed to remove it using a snare. But previously, we advanced a 014 wire in the stellate lumen, and then removing the lead, the wire continue be in the lumen, and then you can proceed to upsize it. Sometimes it's necessary to use laser, and then you can extract some lead, advance a wire, and do venoplasty. For the impossible case, there are some tricks. For example, laser, subclavian recanalization, or you can use a persistent vein of Marshall for CS access. Here, contrast shows both sides of a short total occlusion. And the solution was to use laser, but without any lead to follow. You see the obstruction. The wire is not advancing. Contrast showed the occlusion. And it's very important to advance a catheter from one side and the laser from the other one, and then advance a wire. And finally, do venoplasty. The subclavian recanalization is very important, and it's very simple. You just have to use a 5 French dilator connected with a Y connector and contrast. And if the vein is totally occluded, you can use this system to recanalize. Also, you can use a micro puncture kit to do that. Once the wire advances, then you can do venoplasty. Finally, in this interesting case, there is a patent vein of Marshall, and then you can take advantage of that. And then using a vein selector, a wire, we decided to advance a wire and the vein selector over it to do the case using a patent vein of Marshall. Conclusion, well, use contrast to do a correct venogram, even from both sides, to know the anatomy instead of poke and pray technique. It's necessary to know the available tools and master interventional techniques like venoplasty to optimize the chance of success, reduce implantation time, and the temptation to go to the other side, the jugular vein, or put an epicardial lead. For the total occlusion case, there are options like recanalization and laser without leads or wires to follow. We need to take a decision based on the risk benefit.